Hello guys, this is me Dr.KQ. Today here we were discussing about the ECG series in which we have discussed in previous lecture about the R wave. Today we are going to discuss another segment of the ECG complex, which is ST segment. But before going to start today's lecture, I must say here, go and click on that bell icon and subscribe and share my channel to your friends and colleagues so that you will get my notification for next videos. So coming towards today's topic, which is ST segment of the ECG complex. ST segment is the segment of the ECG which is starting from the end of the S wave and it is ending at the beginning of T wave. So it is basically representing the ventricular repolarization of the heart, and it is the interval between the ventricular depolarization and ventricular repolarization. It is actually a flat isoelectric line. This is the flat isoelectric portion of the ECG complex, and its normal amplitude or height may vary from 0.5 mm to 2 mm in amplitude. So this is the normal height of this ST segment seen on a ECG paper. Next comes here, which is the normal height or amplitude of this segment in limb leads and also in chest leads. It may vary. When talking about the limb leads, it is up to 1 mm, which is normal elevation or which is normal height of this ST segment. While talking about the chest leads, in chest leads 2 mm height is the normal height or elevation of this ST segment seen on a ECG paper. Next comes the abnormalities of this segment. ST segment changes or STT changes can be seen in various conditions of the heart, and there are other abnormalities in which there will be the ST segment elevation or ST segment depression. So there are two abnormalities seen in ST segment. Number one is the ST segment elevation, and the second thing here is the ST segment depression. And this ST segment elevation, when we talk about the ST segment elevation, there comes a point in our mind that this should be regarding the MI. This should be regarding this ST segment elevation should be regarding the MI, which is ST segment elevated MI. We will discuss the ST segment elevated MI and non-ST segment elevated MI in the next videos. But today here the topic of discussion is ST segment elevation. ST segment elevation is not only seen in myocardial infarction, but there are other conditions. We will discuss it later. The mnemonic for which I will describe here is the elevation AB, which is mnemonic to remember the causes for ST segment elevation. So now we are going to discuss about the significant elevation which is usually seen and which is significant for considering the patient for MI, which is myocardial infarction. So how much there should be ST segment elevation in ECG which will consider the patient for MI. There is a criteria which is showing here in chest leads. While you are going to discuss about the ST changes of the MI patient, you will just notice the elevation in chest lead. In chest leads greater than 1 mm and in precordial leads greater than 2.5 mm height is considered significant. And this 2.5 mm height or amplitude of this ST segment is especially seen in V2 or V3 leads. Age factor is another thing here. When the age is less than 40 years, 2.5 mm, greater than 2.5 mm is considered significant, and in all the other leads greater than 1 mm is considered significant when the age of the patient is less than 40 years. But when the age is more than 40 years, then not 2.5 mm but only 2 mm height of the ST segment will be considered significant. And in other leads you will see there will be ST segment elevation which is equivalent to 1 mm may be considered significant. All these ST segment elevation will be considered significant for the patient of MI when it is seen in more than one lead, which is the criteria for the myocardial infarction, that there should be ST segment elevation in more than 2 contiguous leads. So less than 2 leads, you cannot say just by seeing one ST segment elevation in just limb lead or only in chest lead, just in one lead cannot be considered for MI. So basically the point here is the ST segment elevation should be in more than 2 contiguous leads. Now we are going to discuss the other causes for ST segment elevation. There is a mnemonic I have discussed earlier, that elevation AB is the mnemonic to remember the causes for ST segment elevation. Now we will discuss this mnemonic step by step. So this is a mnemonic I was talking earlier, which is easy to remember for the causes of ST segment elevation. So the mnemonic for the causes of ST segment elevation is elevation AB. This is the mnemonic elevation AB. So this E stands for electrolyte imbalance, which is for example increase in potassium level like hyperkalemia. So this is the first condition here. E is showing the electrolyte imbalance, and L is for left bundle branch block. Here comes the third alphabet here. E is for early repolarization, which is a benign condition, benign early repolarization. Then comes the ventricular aneurysm. This is the also condition in which there will be ST segment elevation. T is for trauma like cardiac tamponade. I is for myocardial ischemia like MI, and then comes the O is Osborne wave, usually seen in condition like hypothermia. Then comes the N, which is indicating non-occlusive vasospasm, which is seen in cases like prinzmetal angina. Here comes the last 2 alphabets. A is for acute pericarditis. It is acute pericarditis, not the constrictive pericarditis. Finally, here is the B, which is the last alphabet of this mnemonic, showing the Brugada syndrome, which is a sodium channel defect. So all these are the condition in which you will see the STT changes like ST elevation usually in a ECG paper. So don't confuse myocardial infarction, which is MI, ST segment elevation in MI, with all these conditions in which there is also ST segment elevation. So these are the conditions in which you have seen the ST segment elevation, and these are all the causes for ST segment elevation. We will discuss now the number 1, which is the electrolyte imbalance. We will differentiate all these conditions, that how we can differentiate the ST segment elevation seen in electrolyte imbalance, which can be differentiated from the ST segment elevation seen in myocardial ischemia or in other conditions like Brugada syndrome. So we will discuss step by step the conditions or the causes for ST segment elevation. Number 1 here is the electrolyte imbalance. Now in electrolyte imbalance, you will notice that in electrolyte imbalance, like in hyperkalemia, there will be the increased potassium level, which will be greater than 5.5 milliaqueous per liter, usually seen in a patient like CKD, or for example the stage 5 CKD patient, in which there will be the increased level of potassium. So there will be the changes usually seen on an ECG paper of these type of patients like CKD. But before going to discuss about the ECG changes, I must say here there will be also some pathophysiology behind it when there is an increased level of potassium in the body. When potassium is increased or greater than 5.5 milliaqueous per liter, you will notice that there will be the suppression of the impulse generation from SA node, as SA node is the pacemaker of the heart. When the impulse generation is suppressed, there will be decrease or reduced conduction through the conductive system of the heart, and this will lead to the reduced myocardial excitability. So this is the pathophysiology, little bit pathophysiology behind this. So our basic concern here is the changes in ECG of this type of patient, in which there will be the electrolyte imbalance like hyperkalemia. The earliest change you will notice on an ECG will be tall tented T waves, you will notice the tall tentative waves. Then you will also notice the widening of PR segment. There will be ST segment elevation, and this is the cause for ST segment elevation. Then you will also notice the flattening of P wave and the widening of QRS complex with the PR segment lengthening. All these are the changes you will notice on the ECG paper of the patient of CKD, or there will be the conditions of hyperkalemia. Then comes the second one here, which is the left bundle branch block. In left bundle branch block, there will be also ST segment elevation, and there will be the widening of QRS complex also. So these are the changes of left bundle branch block usually seen on a ECG paper. Here is a mnemonic. You have to remember, we have discussed this mnemonic earlier in a previous lecture, that is Williams. This Williams is showing W-shaped S wave in V1, in lead V1, and M-shaped R wave usually seen in a lead V6. So this William is actually showing the mnemonic for remembering the left bundle branch block, and there are also the causes for this left bundle branch block also. The mnemonic is also here: A2, D2 and H2. A2 is the mnemonic showing A is for aortic stenosis, and the second A here is showing the anterior wall MI, and D2 here is showing D. First D is showing digoxin toxicity, and second is DCMP. H2 is for hypertension and hyperkalemia. So A2, D2 and H2 are the mnemonics to remember the causes for left bundle branch block. So these are the conditions we have discussed. These two conditions, number one here is the electrolyte imbalance, then we have discussed the left bundle branch block. Now we will discuss the benign earlier repolarization, in which you will notice the ST segment elevation. So in both conditions we have noticed the changes in ECG and also the ST segment elevation. Now we will discuss the benign earlier repolarization. Now before going to discuss this benign early repolarization, I must see here, if you people are still here watching my video, please do subscribe my channel and share it to your friends and colleagues, and also click on that bell icon so that you will get my notification. So without wasting time, let's come towards our topic, which is benign early repolarization. In benign early repolarization, you will notice the ST segment elevation, but this ST segment elevation will be widespread. This benign early repolarization is the normal variant. It is not considered as a cardiac disorder, and it is usually seen in 10 to 15% people. Now, how will you differentiate between the ST segment elevation in myocardial infarction and also in benign early repolarization? I have written some of the differences here, like number one here, in benign early repolarization you will also notice the ST segment elevation but no reciprocal changes in ST segment in the precordial leads, while in MI you will notice that there is a ST segment elevation but there will be the reciprocal changes also in the precordial leads. In benign early repolarization there will be the ST segment elevation. In both conditions there is the ST segment elevation, but in MI the ST segment elevation will be greater than 2 mm in amplitude, while in BER there will be ST segment elevation but less than 2 mm. Here comes another difference between these two is on serial ECGs. When you go for the serial ECGs over the time, you will notice that in BER there will be no progression of ST segment elevation, while in MI we have noticed that over the period of time there will be the ST changes you will notice on the ECG paper with the serial ECGs. I have discussed here all the scenario how the ECG changes occur in myocardial infarction. The earliest change you will notice in myocardial infarction, here is the giant tall T wave you will notice on the ECG paper. Then you will also notice the ST segment elevation, which is most prominent in more than 2 contiguous leads. There will be the appearance of Q wave you will see on a ECG paper. Then you will also notice the ST segment return. There is the ST segment elevation earlier here. Now the ST segment return to its normal, but there will be T wave inversion, which is also seen on a ECG paper. Then you will also notice the loss of R wave in a ECG paper, and finally you will notice this T wave will return to its normal position on the ECG leads, but there will be the persistent Q wave seen in myocardial infarction. This persistent Q wave is usually seen in lead 3 of the ECG paper. So this is the difference how the MI patient is differentiated from benign early repolarization. Now comes another condition or the cause for ST segment elevation. Here is the ventricular aneurysm, not repolarization, ventricular aneurysm. This is the condition in which you will also notice the ST segment elevation. Likewise, in trauma, like cardiac tamponade, for which we usually go for the life-saving procedure like pericardiocentesis. In acute cardiac tamponade, we will also notice the ST segment elevation. Actually, we are discussing the conditions for the ST segment elevation. Then comes the myocardial infarction. We have discussed the myocardial infarction earlier in detail. There will be the ST segment elevation in myocardial infarction. O is the Osborn wave. There is the condition, I have discussed it earlier, that in a hypothermia you will notice that there will be the slight ST segment elevation seen on a ECG paper. Then an non-occlusive vasospasm. It is usually seen in a conditions like prinzmetal angina, in which the most common artery involved is RCA, and when the RCA is blocked or there is a occlusion in that artery, you will notice the ST segment elevation most commonly in lead 2, 3 and AVF. Then comes the acute pericarditis. This is also the condition in which there is the infection of the layer around the heart, which is the pericardium. So this is also the condition for ST segment elevation. Finally comes the Brugada syndrome. This Brugada syndrome is also the cause for ST segment elevation. In Brugada syndrome, you will notice the patient usually presents with a sudden cardiac death, and the cause for that death is usually arrhythmia. The drug of choice usually given in emergency is quinidine, or there is also a procedure you will go for that is ICD. And the condition here which we are discussing is Brugada syndrome. It is of 3 types: Brugada type 1, type 2 and type 3. In type 1, there will be the ST segment, coved shape ST segment elevation you will notice in a ECG paper, with also the T wave inversions in V1 and V2. But in type 2 Brugada syndrome, you will notice the ST segment elevation greater than 1 mm, which is saddle shaped ST segment elevation. And in type 3, you will also just notice the ST segment elevation, which is equivalent to 1 mm. So these are the changes you will notice on the ECG paper in Brugada syndrome. So today we have discussed all the conditions in which there will be the ST segment elevation in detail, and in the next video we will discuss another abnormality of the ST segment, which is ST segment depression. So what are the conditions which are leading to ST segment depression will be discussed in my next videos. Hope you like my video. Thank you very much for watching. I'll see you in my next video. But before going to end my video, I must say here again that go and click on the bell icon and do subscribe my channel and share it to your friends, so that we will be in touch in next videos. Hope you like my video. Thank you very much for watching. I'll see you in my next video.